So thank you, Alok boss. I will say only boss because he was my super senior in my time, and he was the person who inspired me for the cardiology. We both were doing DM. He was third year, I was first year, and from that time we are having a good association and academic discussion on and off. And thank you, Banaras, for giving me opportunity to speak. Before discussion, let me come to the point. What sorry. So regarding the so far whatever the discussion we have done, everything was going towards the science where we are dealing with the technology. But the syncope is one of the area where we are still going by the older, or we can say the conventional way of approach. Medical science has not changed too much in this field, and in the coming slide, I will try to be brief and be pointed what are the things we can do in the syncope, because syncope is a very big, vast topic, and it needs a lot of discussion at each point. If you see, this is one of the, I will ask from the audience what they are seeing and what they are feeling regarding this case. So this patient, he came to me, and this is a slide he brought to me, slide, or we can say, the camera there which has been installed in his area. He was walking. His wife was going outside for getting the vehicle ready. He was not feeling well for almost 2 to 3 days, and they thought that we will be going to the hospital and see what is happening. So he fell down. And usually this is the thing for which most of the time patient reaches to the emergencies, or you can say to the hospital, and immediately the first thing will be either the TIA, syncope, or sometime not giving too much thought, send the patient for the CT scan and the things. So what is the opinion of house? What do you feel? Is it TIA, syncope, or anything? I think we will come on this point later on again. So syncope, fall and loss of consciousness. These are commonly confused what you call pathology, or you can say the terminology sometime. And you will see the patient is not going to the appropriate department. Most of the time this patient will be landing up to the neurologist because loss of consciousness is there, which is a part of the syncope also, fall also, and loss of consciousness. Sometimes they will be going to the cardiologist because some complaints will be here and there, or they may be thinking that probably the cardiologist will be the best persons. And in the elderly, a lot of patients are being evaluated by the orthopedician. They will be putting the hip joint replacement. Patient will be doing fine, going home, and later on 2 or 3 weeks later they have died. And the reason is only one: they have not been properly evaluated where the problem was lying. Some of the patient, if the patient is young or in the pediatric age group, they will be presenting with the complaints of some wake, some giddiness, some loss of, and particularly if the girls or if they are in the young age, it may be in the function, so they will be going to the psychiatrist also. So this is a challenge, and what we can do in the present scenario. The first thing, we have to establish the diagnosis of syncope is there or not. And that diagnosis, we have to show that the patient is having transient loss of consciousness, followed by absence of the postural tone, so that he is fell down, or whatever the posture he has just fallen. And there was complete and usually rapid recovery. So any loss of consciousness which is lasting between 10 seconds to 30 seconds is usually the time in which most of the time the patient will be becoming unconscious and immediately recovering. Because the RAS system, reticular activating system, only the 10 seconds is enough to make the patient unconscious, and later on the patient recovers. And when it comes for the investigation point of view, whatever the terminology, either it is AI, CT scan, MRI, or angiography, or whatever investigation presently available, we are having a very less yield. And that's why I was saying the conventional, whatever discussion was there, this is the present scenario, or we can say even the best of best technology, we are not able to diagnose. And you can see the clinical yield is the best even with the history. So history has got, or you can say still the medicines, if the syncope we have to evaluate, the medicine is the only way to get through the cause. Because whatever the investigation, even we are doing the EP study, it is only 49%, and if you are going to evaluate for almost 1.5 years, the yield rate may be around 65 to 88%. And the history taking, which is the most painful. taking a BP and second is the history is the most difficult. Nowadays people are not doing also. They don't want to take. And in this, the history is not of that. The history should be like a CID. You can't go very superficial that he fell down and the fell down means something like a slip. You have to evaluate, you have to go through the history. What is diabetes, hypertension, any risk factor, any palpitation, any giddiness, anybody who has seen the person falling, what exactly has happened, how is, which side he has fell down, and finally how much time it take to recover, any abnormal movement was there. All those things has to be taken. But as a practitioner, we have to know which of the falls are important, where you should not miss. And these are the syncope. With the injury, particular job, if the patient is having driver or pilot, or if he's having a structural heart disease, means patient is having hypertrophic cardiomyopathy, or the structural means patient is having coronary artery disease, LV dysfunction. Those type of patients you have to evaluate thoroughly. Or syncope with the bundle branch, either it is a RBB, LBB, or any AV conduction disorder in which a PR prolongation is more than enough, or the patient is having a sudden cardiac death history in the family, or you have already having one family member having the channelopathies. The goal of evaluation of whole, what we are doing is to prevent whatever the patient who are having the underlying heart diseases, myocardial ischemia, WPW syndrome, and life-threatening diseases which can kill the patient. But it is not only up to that. The ultimate goal is to make the patient safe and the safety of the doctor. If you have missed, it may be a legal suit for you. So if at all any patient is coming of syncope or sudden death in the family, if you are not able to give a time for the patient, kindly give to the person who can evaluate. And I think the cardiologist, in which the electrophysiologists are love to take this type of patient. I think Daljit is there or not, he has left. So we get what is called orgasm to get this type of cases, because it is not a straightforward case. You have to try to go in different direction and finally come to the conclusion. Now coming to the cases regarding what we have seen, which will certainly give the investigative investigation tool how we are diagnosing. So this is a 15-year-old girl having the palpitation and loss of consciousness while playing. And it was present from since childhood. She was on anti-epileptic, and that was Gardiner. So 5 milligram Gardiner, later on 10 milligram Gardiner, she was doing fine. Fine means the patient has adjusted. Whenever we are playing, we have not to go to the peak. If at all peak is there, take the Gardiner and be comfortable. So her Gardiner means the phenobarbital has reduced the frequency, but it is not totally controlled. And so this is a seizure patient. And this is a baseline ECG which has been of the patient. If you can see, there is short PR interval. So this patient has been referred by a cardiologist to me. You see, this patient is having some palpitation. I am getting short PR interval. Why don't you do a EP study? He will get a free treatment from the government scheme. Arogyasri scheme is there in our state. So I thought, let me go. But for doing the EP study, again the patient has to pay around 30 to 50,000, which patient was not ready. Patient was very poor. So I thought, what next we can do? History-wise, I was very much convinced that it is not a clear-cut what she is saying as seizure, it's something else. So this is the TMT of this patient. And the TMT is the tool in which a lot of EP cases, or you can say syncope cases, you are able to get to the point. You can see there are something is happening here. The VPCs are coming. Now something is again. Anybody can say what is happening here? This is very diagnostic. And this is diagnostic because if somebody has read in the brown world, it is written the language, the patient heart rate when it is going between 100 to 120 to 126, the patient will be having VPC, and after 126 heart rate, the patient will start throwing the VT, and that is called bidirectional VT, which is very characteristic only one condition from the channelopathy point of view, that is called CPVT or aconite poisoning. So this patient was having and later on it is totally reduced. The time the heart rate is reducing. So this patient is a case of CPVT, which was diagnosed with doing a simple TMT test. If at all, if you are doing TMT, it will guide for two things. One is CPVT, and some patient of long QT you can diagnose and even establish also. It is a long QT 1, 2, 3, which is comprises around 90% of. So TMT should never be neglected in a patient. If you are having a doubt that maybe having arrhythmia as a cause, kindly do it. patient was put on Inderal with flecainide 50 milligram BD, and after that there is no syncope, scope, no collapse. And now the challenge is she is coming that I want to become pregnant, what to do the next. So she is right now in my follow-up, and this is the OPD pics what we have taken. This second patient, this is a 72-year-old hypertensive non-diabetic with palpitation, recurrent syndrome with a carotid stenosis. And carotid stenosis, he is coming to an electrophysiologist that you should do the carotid stenting. Being a cardiologist, I have to take the case, and then I told we have to go for the EP study as well as angiography. Sorry, angiography followed by the EP study, because he has given one insight that he is developing some giddiness and palpitation. And I wanted to, he is around elderly patient, and angiographically he is having only single-sided carotid disease. Single-sided carotid disease can't lead to the syncope. The patient is having syncope, but it is single-sided. We did the angio, and angio-wise you can see both the side is having non-significant stenosis. And after that we did the EP study. And EP study, the good thing is that we got the patient is having only PSVT, AVNRT, and during the AVNRT the patient blood pressure was falling, and this is one of the common entity which has been missed most of the time by even the cardiologist also, because we don't think about it. The patient, if they're having a PSVT in 72 years, they will present with a fall, or they will present with sometime with the fractures. So these are the patient where if you do a basic ECG, or if you take a complaint of palpitation or giddiness which is provoked or unprovoked, it is a possible. So learning point is always try to think about the common presentation or rare presentation of common disease than the common presentation of rare disease. And AVNRT was the cause. After ablation, the patient's syncope was over, and there was no need of any stenting. Regarding pre-syncope with the ECG and RBB, this is a very common entity. Means most of the time RBB, we are confused whether the syncope is due to the RBB or we are missing something. So this is the ECG of the patient, and in this ECG, anybody can say what is happening in this particular ECG? There is RBB, there is a very clear cut. But RBB, there is one important lesson is that whenever the RBB is there, you should always try to see the S wave. If you are getting a RBB pattern here and you are not getting S wave in this lead 1, it is saying that not only the right bundle is diseased, it is the left side posterior fascicular block is also ongoing. So a patient with the RBB without the S wave in V1 lead 1, it is an indirect marker that you are dealing a case in which the bilateral conduction system problem is ongoing. A history of a syncope or a giddiness is more than enough to clinch the diagnosis. And this patient was having the masquerading bundle branch block, where the pattern will be of RBB with loss of S wave in this one, or it will be precordial, the masquerading of S wave will be there in the left side leads. So putting pacemaker is the final solution for that. So 23-year-old recurrent palpitation, and this is the ECG of the patient. Whatever investigation available in our usual routine investigation, it was normal ECG wise. You can see first ECG was normal, second ECG was having some insight, and this was the insight I think previous speaker Dr. Daljit has already discussed. So anybody can guess what is there? So the patient was having the Brugada. So syncope with no family history. Later on we ECG wise, the patient was having a Brugada pattern, and later this patient was put on this is a very classical saddle ST elevation with T wave inversion, which is class type 1 Brugada changes. And whenever you are dealing with any patient of arrhythmia, try to concentrate these 3 leads, because these 3 leads are most of the time noise, but most of the information will be here. T wave inversion, epsilon wave, or even delta wave, whatever. Delta will be generalized, but these are the where you will be getting the most of the information. So anything which is going out of presentation in the previous ECG, it may be a new finding and it should be evaluated. The patient was put on the AICD, and after that patient was fine. 1 or 2 shock has happened. For that we have put the patient on the drug. This is one of the interesting case. When I was doing my DM, that time the patient I have been given to evaluate. It was in 2009, 2006 or 2007, sorry, 2007 only. The 58-year-old male, history of CAD, EF45, CAG, non-obstructive CAD, and 2 recent episode of syncope has happened. And again, the syncope, if you do all the tests, Holter normal, EPS normal, MRI normal, CT normal, NCS normal, EEG normal, what to do next? And this was the challenge for me also and for most of the general physician, cardiologist. I think 1 or 2 more slides will be there after that. And not only that one, we have done the tilt table test also, it was also negative. So this discussion was going on with one of my colleague who was doing night duty with me. He was a very senior person. He told, you have done the tilt table test? Yeah, I have done the tilt table is negative. Are you sure? Yes, I have done. Then बोला कि तुमने one step I have missed. So sorry. तुमने शायद carotid sinus massage नहीं किया. And the time we did the carotid sinus massage, there was a, you can see. So in our center, there was a mandatory when you are going to for a tilt table test, you have to do the carotid sinus massage and check whether the patient is having CSS or not. And in this patient, an important history was been catched by my friend. He told that वो स्कूटर बैठती उसकी वाइफ कुछ बोलती उसी समय गिर जाता है वो. ये एक टिपिकल हिस्ट्री बता रहा था वो. And I was not able to catch. वो हम लोग मजाक उड़ा रहे थे वो अपनी बीवी शायद उसको सिनकोप दे रही है ये. But that the general physician was only MBBS. He told उसको देखना उसको carotid sinus का कुछ issue होगा तुम जाके carotid sinus massage करो. Next day I did it and I got it. So that's why it is not the degree which is going to make a difference. It is a common sense what he has picked up because he may have faced this thing and he have guided me and thank God after that I never missed that thing and this was the right carotid sinus massage. And for that the treatment is tilt table training and pacemaker. And not only the pacemaker with a particular mode we call as a RDR. The rate drop response method protocol is there. And it is not a very uncommon. The time the person is going elderly, it will be happening. And in that situation, you have to keep a doubt. And if you can see, the persons who are in more than 80 years, they will be having 41% incidence of CSS. So it is not diagnostic if the patient is not having syncope. But if the syncope is happening, kindly try to correlate. It make a difference. And particularly this type of syncope will be having a lot of injury. Patient will be coming in a different bladder state and you will not be knowing where the problem is. Everything is coming normal. Or sometimes 2 or 3 stent has been kept and after that they will be coming again. Because the bystander disease has been treated well, but the electrical problem has been left like that. I think this is the last case, a 33-year-old man where we were, and here the case is. So the case what I have shown you earlier, he was a driver having a weakness, walking fall, and after that loss of consciousness 2 days back, admitted in one of the topmost institute in our side, that is Osmania Medical College. And as usual, resident gone there, done the CT scan, normal, neurology workup, give Livipil 1 gram BD, patient is having no issues. Cardiology immediately they jumped to the patient and they told, okay, TROP-T positive, we want to go for the angiography. This is the usual protocol. And patient, even being 48 hours in the hospital, patient told that I don't want to go for any procedure. I am not knowing what you are doing. One is saying brain ठीक है, दूसरा बोलता heart में problem, लेकिन हमको तो ऐसा नहीं. I was unconscious. He's a Muslim patient. He's having financial problems. So finally he came to my clinic. And on seeing the ECG, the interesting part of this ECG, the ECG gives a lot of information which, as a cardiologist, if you see, he will take the patient in the cath lab and he will say, okay, let us do the angiography and fix it. But if you see as a general physician, you will get a different insight. And that's why this ECG is very important. See the patterns. So if you are getting a V1 to V3 T wave inversion, which is the right side of the right side chest lead, and you are getting a T wave inversion in the lead 3, but the sparing in the lead 2 is of something which is very unusual. And this type of picture, whenever you are getting, kindly keep a doubt that you may be dealing with the pulmonary embolism also. So pulmonary embolism will be involving the right side of the heart, whatever the right side leads. And on top, the sparing of the lead 2 will be there. And this was the thing on which we kept the diagnosis, and we did the echo. Echo was right side was dilated. Not only this one, the T wave inversion lead 3 V1 V2 very common in pulmonary embolism. And what we have been taught that pulmonary embolism patient die most of the time. They will come like this one. They will be young patient. They may be having a PCOD and they are taking some treatment, later on collapse. They will come to us, and most of the time they will be going from one pole to other pole for the treatment. And what has been neglected in this patient was the history. The syncope under evaluation for 4 years. He's having the documents which he has not brought to the hospital, but nobody has asked him. He has been treated for the severe PH 4 years back in 2020. Non-diabetic, non-pulmonary embolism, thrombolysis has been done, and after that, single vessel, the patient was having single vessel disease, for which the patient wanted to coronary artery angiography, which he has rejected. So this was a story, and he was been on the dabigatran, which he has stopped, and later on he developed. Means he has taken for 4 years, and he stopped for 6 months. And the history was the important thing. History, ECG, and the presentation was more than enough. And this was the echo. So pulmonary embolism was the diagnosis in this patient. And this is the important. I think I will impress on this one. Whenever you are seeing that T wave inversion V1 to V1 and it's AVL, but not in lead 3, it is a coronary artery disease, LAD disease. If in the patient with the acute pulmonary embolism, V1 to V3 will be having T wave inversion with lead 3 but sparing of lead 2. And Takasugi syndrome will be having T wave inversion all the lead except AVL and AVR. So if you are getting this type of pattern, kindly keep these 3 things in your differential diagnosis and make the. So final message, cardiac syncope around 10% of the patient. Changes will be always there, ECG will be dynamic. And what defines how we rise after falling? It is the doctor. A doctor with having a clinical mind will make it. And old way would not open the new door. But in the history of syncope or in the clinical scenario of syncope, it will be the old door will going to open the new doors.
Thank you, Dr. Ashutosh, for such interesting cases you have presented, and those are very clinically important cases. Now, if we have got any questions, we can take those questions also.